That's oh, jeez, we're on. Sorry about that. G'day, I'm Ttt Tv. I don't really have time to explain why that's the case, but I'm going to introduce this rock star to you in just a moment. But if you don't know him already, that is, first of all, let me introduce myself. I help foot fixers take their skills to the next level so that you can shortcut your path to the leading edge of your profession. I've been a health practitioner now for over 30 years. I had the great privilege of training foot fixers. That's now over 22 years. So if you're a physio, chiro, osteopath, podiatrist, physical therapist, then welcome, you're in the right place. Thanks for joining us here on Ttt TV. That's Ted's Tips on Tuesday. Are we going to show them Ted's Tips? No, maybe.
No. Later on, maybe.
Yeah, we'll see. Another coffee or two. Really exciting show lined up for you today. This great guy, good friend, and skillful physiotherapist, Ben Corso. He's agreed to join us in today's show, which is pretty impressive given you were here last week as well.
I came back for more.
Yeah, is that a good thing? Ben, how are you on this very fine Adelaide day that the Aussie cricket team is... I was going to say if it was yesterday, we're in really good form. Now it's a little more interesting, and you're going to the cricket straight after here, aren't you?
Absolutely, TJ, yes. No, very well, thank you. Thank you for having me again.
Good.
Looking forward to the cricket. I think I was saying to you earlier, I've a good friend in town, so he's planned to be here just for today. Mm-hmm. So I think he's picked a very good day.
The perfect day.
I think we've got a good contest.
It looks like we have got a contest. Now, you didn't mention, it's your friend, professional friend or personal friend?
Personal friend. He's actually a cinematographer who works all over the world.
Oh,
so he's happened to come back to Adelaide for a day or two just to watch the cricket. So that's how much he loves the cricket.
Okay, so that's I guess will we see any footage? Oh, sorry. Podiatry pun there.
That's a good point. Footage.
Yes.
Yeah, I speak to him about that.
All right, great. So last week, this man here, BC, Ben Corso, he set the whole Facebook FMT community on fire with a mountain of, you had insights, you had evidence, particularly in relation to osteoarthritis treatments. And today we have another contributor, a tale of, she's going to tell a few tales. She's already had, there was a flesh wound.
Yeah, I'm going to block.
Yes, that Ben's already been subjected to. Look, if you missed last week's show about treating knee problems, you can still watch it on Foot Mobilisation Techniques Facebook page, and it's also on the footmobilisation.com blog page. Okay, so today Ben is going to continue this discussion on the knee. We're going to explode some of the osteoarthritis myths, and you may not even understand that they are myths. Then we'll also unpack the factors that may be impeding your treatment results, particularly with osteoarthritis patients. And these are fear, food, and fitness. And that's what today's topic is about. You're going to leave today's show with clear evidence-informed understandings to improve your clinical outcomes. And I think someone's going to leave the show with a pen in their mouth. Right, we're really going to look at helping you improve the clinical outcomes for your patients and also the evidence that supports what we've got lined up for you today. So today's show, fabulous. We're chock full of valuable references and the key actions that you can take to help your OA patients. And I'll be telling you all about these and how you get your hands on them in just before the show ends. So stay tuned. All right, today's show is for health practitioners who feel that they could or would like to offer more effective treatment options for patients suffering from OA in their lower limb. Or we're going to get some paper cuts happening.
I'll lose my notes.
Look, if you already have your osteoarthritis patients totally taken care of, or you're not interested in the latest evidence-informed treatment options, then I was going to say, go check the latest cat video on YouTube. But we got our very own mascot and cat who's doing some wild things with us right here. You might want to stay tuned here for that, if nothing else. Before we kick on, let's just recap. last week's Ttt show, we reviewed the evidence that compares drugs with exercise therapies. We also looked into the key factors that influence practitioners' clinical reasoning and treatment recommendations. We went through a big list of the research and a lot of rigorous research. The thing about Ben is he is not only an excellent clinician, business owner and private practice, but also has a great analytical mind. And so the work you do...
You're very generous.
Not at all. I always feel like I'm in very esteemed company when you start quoting the research. And looks like you've only got about 20 pages of materials here.
Got a little bit today.
Yeah.
Just a little bit.
Here it comes. All right, if you missed last week's show, just scroll down this page and you can get the full list of the references that was cited. We've got a freebie that covers all those details for you. All right, now let's kick on with today's Beducation show. That's Ben and Ted. Beducation. Maybe that's the way you can get your education.
It's good enough for now.
Lying down?
Yes, lying down.
Okay. If you want to get a cuppa and have a lie down, we don't mind. That's all good. Now, let me just see if I can make sure we got all of our materials here. All right, so as promised, we're going to really run through some of the key myths that take place. Manuel, hola! Remember Manuel from Roma? Of course, look at that. Look at this man here. He even remembers you. And that's only because he's had 2 of the coffees before we got started. Okay, so we certainly want to acknowledge Professor David Hunter from, is it University of Sydney? University of New South Wales?
I believe so. But this is more in relation to a podcast that we both listened to some time ago.
Yeah, yes. So there's a great podcast that Professor Hunter went through that literally it started up a whole lot of discussion we had, and we were both interested in the topic, and we knew that the FMT foot fixing family would also be interested in this. We're taking things a little bit further than foot fixing because there's also references to knees, hips, looking at the whole kinetic chain, the impact that the foot has on the leg. I probably digress a little bit here, but you were talking last Friday about how the pelvis and the hip and how it can affect the knee and the foundation. I keep pointing out to Ben that the foundation is at the base, which is the foot, and that's the important area there. But he actually had some good counter arguments. So I think that's coming up in next week's episode.
It's all good discussion.
It is. All right. So, welcome, Ben. Now I'm going to let you. I think I've used up all of my word count here. Let's go through. We got 5 myths that we're going to be running through. The first one is osteoarthritis is a wear and tear process, isn't it?
Well,
why is that a myth?
It really, I guess, comes down to who's advising you accordingly about the process of arthritis and who's educating you. There's no doubt that there is a wear and tear component to the condition.
Okay.
But what we do know is that a number of people, in fact all of us, will show some degenerative changes in our joints after a certain age, which is probably a normal part of ageing, rather than being a process that involves destruction and damage, etc., which tends to be how that wear and tear process term, if you like, or degeneration term tends to get thrown around.
Did you see how he was looking at me when he said age, wear and tear and degeneration?
Yeah, well, you were a great example. But no.
Yeah.
So I think in the podcast, Professor Hunter refers to it being a dynamic process, whereby there is obviously a destructive process, but there is a repair process as well. Now, that's not to say that we are trying to eliminate the condition. We know it exists, but maybe what we're seeing in relation to how people respond to treatment or how their symptoms progress is that they're actually having a normal process occurring, but they're having flare-ups along the way. So they have good or bad periods, which we're terming flare-ups.
Yes.
But that may relate more to them either overloading or, which we'll discuss later, underloading, as in not doing enough.
Ah, okay. Hey, I haven't run this by you before. I heard a great analogy for the wear and tear and osteoarthritis, actually by one of your colleagues, a physio based in Sydney, Sarah Key. And she described it beautifully in that it's an analogy that I've used a lot in my clinical experience as well. Think of joints like grass. And if you walk over the grass, it's like grass grows from up, and then the wear and tear over the top means it wears down. As long as the grass grows, or with the analogy, cartilage grows quicker than the wear and tear on top, you get a healthy balance between the two. This way, you don't have to explain to patients, osteoblasts and the chondrocytes and all that sort of stuff. It's like grass, because everyone can relate to grass.
Yeah, look, that's probably a good analogy, I guess. And then if we took that further and talked about what effect our treatments are having, maybe we're the fertiliser and the watering for the grass.
Okay, but the grass then keeps on doing its own thing.
That's right. So I guess in this scenario, you're talking about, maintaining a stable base, if you want to call it that. And then controlling the load that you put on that grass. To make sure that you have, the ideal conditions to keep functioning. In that sense.
Okay, and then if we think of Adelaide Oval, 1 kilometre down the road here, have they prepared the grass and the pitch? Looks like it's a pretty even pitch and it's going to last the 5 days, okay?
Absolutely.
Damn, we should.
Hope so.
Okay, myth number 2. Joints only have X number of steps available in a lifetime. Now, why is that a myth? What do you mean? Isn't it... I always thought, once the joint uses up this amount of movement, then that's going to be it, isn't it?
Well, again, it probably relates back to that first myth, is that if we're talking about the condition being dynamic, in theory what we're saying is that there is the ability to change. So whilst the joint itself might appear in a certain state, that doesn't relate necessarily to how that joint is functioning. And we know that from the radiology investigations looking at arthritic joints, is that the radiology doesn't correlate with the symptoms or the clinical presentation. So just because a joint looks the way it does doesn't necessarily mean it's going to function a certain way based on that. And I think we might have talked about this last week, but we see people quite frequently where they have quite significant wear and tear changes on their investigations, but actually still function really, really well. And then the opposite is true. So it can't always be the joint itself that is necessarily giving us the end result in terms of what equals these sorts of symptoms or this functional limitation.
So are you saying that diagnostic imaging, the objective diagnostic imaging, may not be as accurate as objectivity would require? I think it's like anything. You shouldn't put all your eggs in one basket. Okay. So the imaging is important to a degree, and it's probably important in certain circumstances. But it shouldn't be the thing that you base all of your clinical decision making on. It should be a tool to really assess or guide your treatment. And again, I think going back to that podcast, I think one of the references discussed there was looking at MRI scans and how frequently MRI scans will reveal a cartilage tear. That cartilage tear is probably asymptomatic, and a high percentage of people have those cartilage tears on MRI and have no symptoms. So once again, is that helpful or is that unhelpful to know that information? Because it certainly could. Because then when patients find out, it's like, well, that explains. Like with feet and heel spurs, I've got a spur, and yet we know that there's no direct relation to symptoms.
So I think in that setting, X doesn't equal Y. It may be something that's important to know as part of the whole clinical picture. But if you're relying on the radiology and you're relying on the look of that joint to make your decisions, you're probably going to get pretty inaccurate outcomes.
Okay, we need more bits of the alphabet, so bivalve. Is that what you're saying?
Thank you, yes.
All right. Okay, myth number 3. Arthritis can't be cured. Once you got it, eventually you'll end up in a wheelchair. Why is that a myth?
Well, again, if we relate it back to those first 2 myths, there's this, the language that we use to describe this process to patients, I think, is part of the problem. such that if we start to say that destructive, degenerative wear and tear, it's already giving the impression, I think, clinically, that that particular joint or that particular condition is going to get worse. It's going to deteriorate. It's going to progress. If it happens to be in a patient that is struggling to walk because of it, it's probably quite logical to the patient, don't you think, that if they are struggling to walk because of knee pain or hip pain, and then they are getting advised that it's wear and tear, it's destructive, it's degenerative, it's going to progress, it's going to get worse.
Yes.
It's probably logical for them to then think, well, that means I'm going to have to stop walking and I'm going to end up in a wheelchair. I think the facts are that if osteoarthritis is present, it's present, but there are many, many strategies we can use to manage it quite effectively. So to use the term cure is probably not a good term to use for a start, because we're not talking about cure, fix. We're talking about manage. And this is where I think that the problem occurs, is that people get away from this idea that they can actually manage it very effectively. They're only thinking, can I cure this or I can't? And when the advice is, no, you can't cure it, they automatically then give up and go, well, okay, well, I'll stop doing everything. So it's a myth in terms of perhaps the way it's communicated, and then what the patient's perception is of what this actually then means for them, the individual.
And what about practitioners? Would they also take that languaging or opinion?
Yeah, look, subconsciously I think that does occur, and we know from some of the research into other areas of the way therapists provide treatment that for certain conditions, and I'll use the shoulder as an example, but we know that the therapist's beliefs have a strong impact on the outcome. So if the therapist has a belief that, Ted, your knee is stuffed, to use an Australian term, or it's wearing out, or the surgeon has told you that that's the only option is to have a knee replacement, if the therapist's belief is that, gee, I might not get much success with this fellow because there's all this going on, then that in itself probably has a negative impact on the outcome.
Okay, now you on Friday, you did actually quote a paper that ranked the elements that determine the success of the outcome. And I think you actually, come on, what was it? This was, you quantified what was the number one factor that influenced. I'm not sure if I'm using the right term.
Yeah, no, you're right. I was talking about this shoulder research, and they looked at, and we'll find the author so we can quote that. But, they were looking at the success of a conservative management after a rotator cuff injury, a rotator cuff tear of the shoulder. And the number one predictor of a successful outcome from non-operative treatment was the therapist's belief. The therapist's belief that program was going to be successful for that individual. So out of all the things that you could look at in terms of, mobility and strength and all the things you could clinically test, actually what came out on top was the therapist's belief in the treatment approach themselves.
Damn. So that's the responsibility we have as a therapist then. Okay.
So I think with this example, the therapists, podiatrists, physios and others just need to be careful. We don't get caught up in the language that people are being told from everybody around them. And that we need to objectively and clinically assess their presentation on its merits and provide them with the right sort of information. Because there probably is a danger that we get swept up with it as well, and we start to think, well, this person's been told they're going to need a knee replacement. We're not going to really be able to do much, are we, Ted?
Right, okay.
And then that itself negatively impacts.
Yes, I can see some whole, on many different levels. Who's the authority, who is the trusted advisor that that patient will believe. Okay. Right. Next myth, jogging. Now, surely jogging causes arthritis. That's just a given. I mean, I was taught that from way back and still hear that.
So this is a really interesting one, I think, and I know when you and I were listening to that podcast, we were discussing this. I think the general consensus in, I guess, the work that I do and the patients that we see is that most patients, let's take knee arthritis as the example, are generally being advised to avoid high impact loading. Now, we would term things like running in that bracket.
Yes.
So we'd be tending to advise people to swim, walk or cycle as a primary form of exercise that was safe, and to avoid things like jumping, hopping, twisting, turning, running. And obviously we include jogging in that. Well, after obviously then looking through some of the evidence, well, actually we may have to change our thinking about that advice, because a lot of the research that's been done in the reviews of late have actually shown that being sedentary is a much bigger risk factor for the development of arthritis than exercise or activity, which includes jogging. And even if you've got arthritis, it seems to indicate that if you're a low or moderate distance runner or recreational runner, we'd call them, so obviously someone who's not running marathons or doing really high levels of training, that actually that activity, the jogging, could actually be protective of developing further arthritic changes.
Actually protective. I don't think she's going to attack you.
No, she's not. She just wants to sit on me.
She does. Well, uncross your legs so she can get onto your lap properly.
So where this is relevant to our patients is that jogging or running is one of the most common things that patients will say to us that they'd like to keep doing.
Yes.
And quite often it's one of the things that they've been advised that they should not do.
Yes.
So you can imagine, again, from the patient's perspective, being advised to take something away from what they actually love doing and what impact that might have. Now, which then leads into what we know about arthritis and the fact that levels of depression and anxiety and those sorts of things are higher in these patients. How that information in itself could contribute to this sort of almost downward spiral. So I guess the message is that the evidence doesn't support the fact that jogging necessarily is bad for your arthritis. In fact, quite the opposite, it may be very good. That's something that probably needs to be assessed on a case-by-case basis.
Yes.
But the first piece of advice may not be, we need to give up running now.
Yeah.
We may need to be a bit more selective with that advice.
Oh, good. I remember a conference where David Butler spoke, and he talked about the importance of doing something that you love as part of your therapy, rehab, recovery. And this doesn't it's often it's the things that they love that we think got them into trouble, training for the city debate or the dance floor or whatever. So yes, how important it's something you do something you love. Yeah,
and I think we see that every day when we're trying to advise people about exercise. Well, one of the first things is to find out what that individual's goals are of treatment. So if they're coming for treatment, what are your goals? And then obviously trying to work around those goals as far as directing your treatment accordingly.
Yes.
There's no point getting somebody to perform an exercise program that which involves exercise that they don't otherwise enjoy doing and don't want to do.
Yes.
If you can somehow make it focused on their goals, whatever that might be, again, things like walking programs, jogging programs, they're probably going to buy in a little bit more to your advice, and they're probably going to adhere to it for longer as well.
It makes logical sense.
That's my clinical sense anyway.
Yep, okay, and I think we're going to come up with some examples here. Just progressing specifically more now that we've covered those myths. Our topic today, fear, food and fitness, and how they impact on our clinical and treatment outcomes. Fear. Now, this is a strong emotion when someone is experiencing fears, and certainly will influence our beliefs about what's going on with us. I suppose that this is important when we look at the influence of it, because beliefs influence the actions that we do or don't do, and then obviously the actions that we do, whether we adhere to the exercise program or adhere to advice that's given, that can then affect the treatment outcomes. I think you were talking about the story where a patient of yours was saw the radiology results and literally was influenced by them. Do you remember the case example there?
Yeah, so I mean there's one I can think of in particular, but there's probably multiple when I think back. But But essentially, yes, it probably goes back to what we discussed earlier about the myth. So, the typical patient that presents to their GP or what have you with knee pain.
Yep.
We know from the information we discussed last week, likes me, from the information we discussed last week, a very few number of those people that present end up getting referred to us.
Yes.
They're much more likely to get referred for an X-ray or for a orthopaedic opinion or what have you. Hello. So
Stop using your hands.
if that's the case, you can see how already just by the way they are directed to seek treatment,
yes.
if it is radiology, that we could be in a bit of trouble early on, because naturally they would present, they'd be referred for a plain X-ray,
yes.
and the X-ray will show some degenerative changes. As we discussed earlier, it will show in most people over a certain age.
Yes.
And so people will draw that analogy between the X-ray and their knee pain.
Yep.
So this particular patient that I can recall, this is exactly what happened. They were referred. The X-ray showed some degenerative changes, some wear and tear. They become very fixated on the report, and of course, to read it as a layman, sounded like the world was about to fall apart.
Right. Yes.
So as a result, they became almost withdrawn from activity and withdrawn from treatment, because their fear and their belief was that this degeneration was going to continue to deteriorate
yes.
if they put pressure on their knee, if they walked on their knee, if they loaded their knee. Because again, we're thinking about it from the patient's perspective. Without that knowledge base, it would actually be fairly logical, even though to you and I it wouldn't, because we understand the science.
Yes.
But it would be fairly logical. If you had a sore knee that hurt you to weight bear, you had an X-ray, someone told you that there was wear and tear, and that if you put more weight on it, that might lead to further wear and tear.
Yes.
So we in this particular case, this patient became completely fear avoidant of activity, of any intervention that we could possibly provide, because it was very hard to change that belief.
Yes.
And so once that information's already been sown, the seed's been sown early,
yes,
becomes a real uphill battle to try and change their thinking.
Okay, so that definitely would impact I suppose the clinical outcomes of that management there. Okay, second item was food. Now, we picked on food because...
We love our food.
We do. It starts with F, so our alliteration was going well, but specifically we're actually talking about fat, aren't we? And so why is food? Look, can you describe what is it about food and fat in particular that impacts our clinical results?
For a start, I'm not a dietitian or a nutritionist. I'm a physiotherapist. So I'll talk about it from our perspective of where it's relevant. So again, if we're talking about an arthritic knee population, which is probably the group that this has been most studied on, that we know from the majority of the literature that a very small change in weight, a reduction in weight for those that are overweight, has a significant impact on knee pain and function. And that's been shown time and time again.
Okay.
And if you listen to the podcast, they then extrapolate that to how many less patients would be presenting with knee arthritis, and potentially how many less patients would be having surgery for knee arthritis. Okay. And so we start to talk in the thousands, and then we start to talk in the millions as far as cost saving goes.
Yes.
But essentially that there are two main issues that obviously as a population worldwide we're all becoming bigger. We know that for those people that are overweight, that is probably the most significant risk factor for developing knee arthritis, is being overweight, over and above everything else. And weight has two elements to it. One is the biomechanical load effect that it has.
Yes.
And that's all logical for most of us, that if someone's heavier and they're putting more load on their joints, then clearly they're at greater risk. But probably of more recent times, they've looked into more the chemical interactions that occur with fat and with weight. And we know that carrying a significant amount of weight has almost a pro-inflammatory effect. So therefore, if you've already got a pre-existing inflammatory joint, and you have carrying excess fat, that not only is it adding a biomechanical load because of the weight, but it's adding a pro-inflammatory load because of the chemical interactions that occur.
Okay.
So it's a bit of a double whammy in a way.
Right. So I can understand the importance and significance of this. But a question that I have to you, dear viewer, is how challenging do you find it to discuss with a patient that they might need to lose weight? Because I know me personally, I'm uncomfortable for a couple of reasons. One, okay, I'm not an authority on the topic of nutrition, but two, it is a personal thing that I would imagine if you feel uncomfortable discussing weight management with the patient, please put a comment down or give a thumbs up or a sad face, that might be more appropriate. And while you're doing that, how would you address that? Like in a clinical situation, how do you cover that topic?
Well, I think the first thing to say is that it is absolutely challenging, and people in our professions aren't trained necessarily in how to deal with that. So the first port of call should be that you seek out the right professional, and that would be where dietitians and nutritionists are really important as part of this management plan. So that'll be the first thing, just to preface that we probably need to be more aware of our colleagues and who's best placed to provide that advice.
All right.
What's important for us to know, though, is to recognise that it's a problem and at least take steps to do something about it with that patient.
Yes.
Because we know that no matter what manual therapy techniques or exercise techniques that we apply as a podiatrist or a physio for these patients, that unless that is addressed, we're doing them a disservice, really. If we're not addressing it in some way, they're not going to get the optimal outcome.
Yes.
So I guess in my clinical practice, the way I would frame it would be to obviously do it in an empathetic and a non-confrontational way.
And before you do that, I want you to tell us the story of that patient that was sent to an orthopaedic surgeon.
Yeah, so I had a patient some years ago who presented to an orthopaedic surgeon for knee pain. And I think in the patient's mind that they were expecting, look, I'm going to need a knee replacement and when are we booking in, sort of scenario. And was advised by the surgeon that, well, look, the first thing you've got to do is lose 20 kilos and I'm going to send you to a gastric bypass surgeon because you need to have that surgery done before I'm going to do your knee.
That was the weight management.
That was the weight management. Now, rightly or wrongly, that in some settings with some individuals that may be a good plan of attack in terms of a management program.
Yes.
I guess the way it came across to this patient was completely in your face and put the patient right off and had the patient's wife in tears and a whole range of other things because it was just very confronting.
Yes.
So that's an extreme version, I guess, of how you'd manage the whole weight issue.
Now, what did that patient end up doing?
In the end, he went somewhere else.
Right. As he didn't go through with the gastric surgeon recommendation?
Not as far as I'm aware. I haven't seen him for some time, but not as far as I'm aware. And I believe he did consult elsewhere. Now, once again, it's a case of, was that the best management plan? It may have been for that patient. But was that the best approach to take to do that?
Yes.
Probably not.
Yes.
Because it didn't quite result in the right outcome.
Okay, now I know you have some references to this observation that when a patient is in an overweight situation, losing 5 kilos makes a significant quantifiable difference. So, here's a patient who's told they've got to lose 20 kilograms. That's probably a pretty tall order for...
So, look, I think it's no different to how we advise people about other things like exercise. We know that there's no point giving people 10 exercises because they're unlikely to do them all and adhere to them all. And sometimes less is best. So sometimes giving the advice to do 1 or 2 exercises and do it once or twice may be better than doing 10 things 10 times because they may not otherwise do it. And I think weight is another area where that's the case. So again, the common story that I would hear is a patient would consult with their medical professional, and they may be 20, 30 kilos overweight.
Yes.
And they're often told, you need to lose 10 or 20 kilos. Now,
Yes.
the majority of patients that I've seen in this situation will just switch off there and then.
Right.
Because that seems an insurmountable amount of weight
Yes.
to try to actually lose.
Yes.
And they can't see a way forward where that's actually possible.
Mm-hmm.
So the beauty of the research with knee arthritis anyway is, as you said earlier, it is generally 5 kilos. 5 kilos for most people would be achievable if they had the right advice and instruction from the right people.
Yes.
And it's also not a figure that would completely make them
Yes.
retract and go, oh my God. They
Achievable.
actually go, I think I could probably do that if you
Yes.
showed me the right way or educated me how to do
Yes, yeah. So it's achievable. Important thing there, making sure that the goals, in this weight example, that they would be achievable and doable. Okay. Then the third element of our discussion today is fitness, and I think we've touched on this already. Where jogging. With the myth that it causes arthritis, but you've actually got evidence to say that jogging can protect against arthritis. Now,
Yeah.
what's that all
Yeah,
about?
so there's good literature there now that has looked at this, because again, it's often been one of those things where we've just advised it without maybe thinking about why. And with
Yes.
this assumption, as you said, with this assumption that it's high impact loading, it'll be loading the joint and the cartilage is already worn down and therefore it must be doing more damage. Well, the running probably works on two elements. One is that the general conditioning that it provides
Yes.
and keeping you fit and active is probably having a positive effect in many other ways, not just physical but also mental.
Yes.
So there's an element there. But of course, some of the literature's then looked at just the direct link between jogging or running and the effect that it has on your BMI.
Yes.
And so if it
okay.
is having that effect on BMI, then in that way it's helping to actually reduce the incidence. So I just said that
Yeah.
being overweight is a biggest risk factor of developing knee arthritis. So therefore it stands to reason if you can do anything that reduces your weight, you're going to reduce your risk factor. So it's probably that balance between, how much running is enough to manage your symptoms without flare-ups,
Yes.
versus how much of that running will contribute to keeping your weight down.
Yes.
Because again, this is the problem we see, and one of those references that we've provided looks at the complete management program that they've looked
Yep.
at in New South Wales, and there's a couple of really good little case studies in there.
Uh-huh.
The case studies are really valuable because they're probably things that clinicians will identify with.
Good.
One of them being talking about people that we just said have gone through that process of knee pain, had an x-ray, been told there's wear and tear, and then you see them withdraw from activity. Therefore, you see them become more sedentary,
Yes.
more overweight, which increases their risk.
Yes.
So it becomes that vicious cycle.
Yes.
And what we're trying to do is intervene to change that because we know they'll get benefit if they don't go down that path.
And it's almost
It's almost the opposite.
and the counterintuitive element with
Absolutely.
that. All right, great. So that advice then of telling people to stop running is may not always be appropriate. Well, what about if people run and they have a flare-up?
Yeah, well, I think it. We just need to examine whether that's good advice to give everyone. I think that's the issue.
Okay.
It tends to be the standard advice that you give everyone that has an arthritic knee, if you know what I mean. So that seems to be the issue, is that there are probably many cases where that advice in itself is not valuable. That advice, in effect, may actually contribute to things not improving.
Yes.
So I don't think we're saying that everyone should run that has an arthritic knee, but we're certainly saying that maybe that advice for some people isn't good advice because the evidence would suggest otherwise.
Okay.
And I think we've got all the references to some of that literature
Yes.
in this.
Definitely have. So into today's fabulous freebie, there is most certainly direct links to... Well, look at that, just conveniently have here. This is the freebie. So today's episode, which is osteoarthritis part 2, the topic, of course, is how food fitness can affect your clinical outcomes. So you'll see both we've got the link to the podcast up the top, and then fear, food, and fitness. We've got direct links happening here, right? So you can grab that as part of our gift of beducation.
And the other good thing about some of the things we've referenced there is that there are ongoing links and references to other work in the same space. So the weight management, for example, and the running.
Yes.
We've got some links there to those particular topics, but then there are further links to, I guess, the bigger body of evidence that's researched that area. So they may be also worth looking up.
See, I told you, this guy's worth his weight in gold. Oh, sorry, I didn't mean weight.
Gold.
Gold, yes, definitely.
Are you saying I've got to lose 5 kilos?
5 kilos of gold, but it's certainly, a valuable thing, and I've given myself completely tongue-tied here, so I better just move right along here. All right, so look, the freebie today is a remarkable resource. Ren, with the freebie, it will be coming up very soon. Normally what happens here is Dr. Lil would be putting the link on the post right now as we speak and refer to it. So once we've finished, I will be doing that because Dr. Lil is actually seeing her periodontist. Oh, that's maybe a little bit too personal. She said, Ted, you gave her a mouthful. Ren, it will be coming up very much. I've got it all prepared. It's here, there's a hard copy. You're going to get that for sure, including the link to the podcast with Professor David Hunter. That'll be happening as well. So if you've just joined us, we've had a very fruitful and fulfilling discussion. And the really interesting thing here has been so exciting that you'll see Penny Lee here has just parked herself and making herself really quite... Yes, she was having a little bit of a snooze there. So that... is one thing that's taken place. Anyway, we've gone and reviewed some of the key myths of osteoarthritis and busted them beautifully, that's for sure. TP, speaking of busting, yes, that's very impressive. All right, we've also explored how fear, food and fitness can affect your clinical outcomes. It's been an absolute cracker of a show. Sorry, no reference or no pun to manipulation techniques. So, look, I've got to say, I'm really looking forward to Ben's workshop next March that we're doing on the knee. It's a full day on the knee with assessment, treatment and management of the sporting knee as well as the aged knee. And your definition of aged or older knee is also something that I think we're going to be coming up with next week on next week's Triple T show. All right, so then so there will also in the freebie be a link to the live workshop. We've already had a great response. It's going to be a sellout, so we're looking forward to exciting adventures in March next year. Okay, what about feet? What can a podiatrist who's taking care of a general treatment client who happens to also have clinical signs of osteoarthritis, whether it be pain on movement in the joints, osteophytes, pain with use, any other clinical clues of arthritis in foot or ankle that you would...
Other than joint pain, swelling, pain on weight bearing, all those sorts of things that you'll pick up in your assessment.
Yes.
I mean, we've been talking a lot about the knee here today, but it stands to reason that many of the topics that we've discussed that relate to the knee would absolutely relate to the foot and ankle and the hip.
Yes.
Because we're talking about weight-bearing joints.
Yes.
And so I think some of the advice we've provided today or the references in relation to some of the topics, and we can look at running, we can look at weight.
Yes.
I think podiatrists are in a perfect position with these sorts of patients to be advising on the most appropriate strategies to help that patient manage, aside from the manual therapy techniques, etc.
Yes. Because of course we know with the health of cartilage and stimulate chondrocyte activity, we need to get synovial fluid there. Yeah. And we know that stimulation of synovial fluid, you need movement within the joint. And that's, if you're not already trained in joint mobilization, foot mobilization techniques, that's definitely something I can help you with. All you need to do to find out more is get the details. That will literally be On the fabulous freebie here, we've got the workshop links there. We've also got special offer for our Ttt TV viewers, where you can save up to $500 on the full 3-day training program. So get your freebie. It's got all the links to the articles, and it's got the links to the workshops and which options you have, whether you're new to FMT or whether you just want to do the knee program. That's an absolute must. Or you want to do FMT advanced techniques with the knee. We've got all the options mapped out for you there. Before we sign off, if you have any questions or frustrations with treating your arthritis patients that we haven't covered today, then please feel free to type them in. Next week, Ben and I, we're going to dive in head first, a bit like Penny has done today, to determine how can you tell whether your patient's knee problem is coming from their feet. And I know you've got some very interesting, really useful and insightful clinical tests that we can go through. We're going to explore that in considerable depth in next week's show. So this will be another evidence-informed
Very good
show. See, I listened, I learned. If you don't know what I'm talking about here, you've got to have a look at last week's show, because Ben articulates beautifully why we are evidence-informed rather than evidence-based. So that's all going to be coming to you next week, starring this man right here, BC. I think there's a fair chance that we're going to have another star right here as well. She will definitely be making herself. She's moved from one lap to the next. You're going to love what we've got in store for you. I got to say, it is going to be just brilliant, if I do say so myself. Thanks very much for joining us today. Let us know what you think of today's show. If it's we've had a wealth of good stuff that we've been covering today with the one and only Ben Corso, and I'm needing to wrap things up quickly because he's heading off to the cricket, which is about a kilometre down the road. Hasn't invited me, but he's got another friend who's a little bit more important by the sounds of things. If you've got a friend or a colleague who you think would benefit from Ben's absolute golden insights into osteoarthritis management and osteoarthritis myths, please share this link with them. Make sure you join us next week for our next episode of Beducation. It'll be a cracker of a show. We might even jump on a mattress and have a pillow fight. No.
That wouldn't be very healthy, would it?
Yes, I don't know.
Then we'll be doing a concussion seminar.
Yes. Oh, yeah, that's just giving me a headache thinking of that. All right. Big thanks to Dr. Lil, who in absentia has played an important role in bringing today's show together. Until next week, same bat time, same bat channel. Remember, you're only one click away from helping more people like never before when you click and grab this download here. I'll say cheers for now, but I'm just going to wrap up as the credits run and show you a little bit of the impact that we have had on some of the local audience. Like this guy right here. What do you think, bully boy? Oh, Tamatu. Yeah. Oh, that's all I'm good for. Okay. And then someone who's going to have their greens. How are you going here, Pen? Think it's all right? All right. That's enough madness and nonsense. Until next time, cheers.